The fourth SAGES HPV webinar. So today we're going to try to talk about kind of the oncologic perspective of some of these diseases that we treat. We're going to focus a little bit less on the surgical technique and more about the kind of the decision making around going to surgery, when to use neoadjuvant, when to use adjuvant, kind of how we approach the patients before we get to the operating room. So just a couple thank yous before we get going. So first of all, the SAGES HPV committee, thanks for the opportunity to moderate, obviously, and thanks for getting these sessions organized. Our administrator, Betty, the glue that keeps us together, Ed Rosado, who helps out with a lot of things. And then a special thanks to the SAGES Facebook task force, who has kind of got all these webinars. You know, there's been a number of these, not just for the HPV group, but for the colorectal group, had a really nice session on rectal cancer very recently. And Andrew Wright has really kind of spearheaded that effort. And then I wanted to give a special thanks to Kevin Alhayak, who has kind of organized all these for the HPV group and has done a nice job of helping us get these things up and running. And I think has done a great job so far. So I will stop sharing, and then we'll go with Dr. Tay first. So Dr. Tay, if you want to share your screen and go ahead and get us going, and then I'll follow along online. And if any questions, if anybody has any questions, please put them in the comment feed, and I can relay them to Dr. Tay.
Thank you very much, Tim.
Thank you.
Okay, so can you see my screen?
Yep, looks good. Looks good.
Okay, so thank you very much to SAGES for inviting me for today's seminar series on HPV, on all things HPV or all things oncology. My topic today is on HCC. The incidence of HCC has been rising worldwide, and currently it is happening more than 80% in the low and middle income countries where resources are actually very much constrained. This is particularly true in Eastern Asia, in Southeast Asia, and also in the sub-Saharan African countries. It is also the fourth most common cause of cancer-related deaths, and Taiwan and Japan actually have shown the best clinical outcomes in the world due to their comprehensive screening programs and intensive surveillance using multiple tumor markers such as AFP, PIVKA2, even DCP, and also strictly regular ultrasound screening and surveillance of high-risk patients. And so more than 70% of HCCs are diagnosed early in these two countries. Unlike in our case, where most of our patients are actually diagnosed quite late in the intermediate stage or in the advanced stage, in looking at the BCLC criteria. And if we use the BCLC criteria, all of these patients will be deemed unresectable and won't be able to undergo any form of other treatment, especially when the treatment processes such as radioembolization, the systemic therapies are all exorbitant. So most commonly we encounter these types of tumors, the HCCs, that we call them as giantomas in our country. And majority are due to hepatitis B virus, in contrast to the West, which is HCV. And also recent past, we see a surge or a rise in NASH causing HCC. Not so much with alcohol. The incidence of alcohol cirrhosis remains to be the same, but much less than Western countries. Now, from the very first release of BCLC, which have defined intermediate as large HCCs not fulfilling the Milan criteria, without any distinction from multinodular HCCs as well. And BCLC also did not define whether large resectable HCC should belong to the early rather than to the intermediate stage when resection is performed under these predefined clinical criteria. We have employed different staging system and different approach towards these tumors, as you see that most of them undergo resection rather than other types of treatment options. And most important is to be able to come with a diagnosis of HCC via imaging. And the imaging not only serves to diagnose or to identify these tumors, but also as a roadmap to assess resectability, vascular invasion, and of course the extrahepatic metastasis, so that we could assess resectability for these patients. Tumor markers are also used regularly, and this also is used for screening and surveillance. So to be able to assess the risk and the resectability criteria, the staging of HCC is important to determine the outcome and planning of optimal therapies. And this includes the tumor extent in terms of size, of number of nodules, vascular invasion, extrahepatic spread, and we also incorporate the liver function and portal pressure and the clinical performance status as well. And the most popular here amongst all the different staging systems is the BCLC, as we all know that. The difference in treating HCC compared with other cancers is that we need to determine the underlying liver function, which affects very much our treatment planning option. And that is the reason why the different staging systems in the East have emerged as our guidelines, because the TNM staging does not have the treatment options, while the alternative treatment algorithms from Asia, from Japan, Korea, Hong Kong, they have incorporated the liver functions and even BCLC as well. And thus, these are the more commonly used staging systems and classifications to help guide the treatment options. We also have to consider the diverse difference in practice between the East and West, between high-income countries and low-middle-income countries, and also the multidisciplinary expertise that are available. In our situation, not every hospital would have the capability to do embolization, whether it be chemoembolization or radioembolization. Even PVE is not feasible in most centers. Likewise, the cost could be prohibitive. So if we look at, again, going back to the BCLC criteria, most of our patients will then be unresectable because they all fall, majority of them, almost 50% of them fall in the intermediate stage and the advanced stage. There was a report in the past that challenged the BCLC, saying that the multiple tumors and the size and even presence of portal hypertension actually does not affect the overall survival, but it may affect the recurrence rate. This was published by Ishizawa, the Japanese group in 2008, and we feel exactly the same, and thus we employ this approach as well to select our patients for resection or for other types of treatments that are available. The Hong Kong group further classified the intermediate group into these three different stages, whether it is an early tumor, intermediate tumor, or a locally advanced tumor, depending on the size and also the invasion or presence of tumor thrombus. So those with the tumor thrombus are also classified as a locally advanced tumor. And so they would still be subjected to surgery or TACE or even ablation in the first stage if they are caught early. We also know that Hong Kong group are also very aggressive in terms of living donor liver transplantation. And so these patients are also given the option of liver transplantation if their child-pugh status is quite poor. The Japanese classification, on the other hand, also shows different resection recommendations depending on the size and the number. Even nodules that are more than 4 can also be subjected to resection, and even those with child-pugh B can also undergo resection in this case. The problem with this Japanese staging system is that there are so many different options in these stages, being resection, TACE, and even systemic therapy, all grouped together under these criteria. The Korean classification, on the other hand, shows the same resection criteria, ranging from single tumors to multiple tumors to big tumors to multiple and multinodular bilobar disease, incorporating various different options that are possible and not very straightforward. So going back to BCLC, it seems like BCLC really has become the more popular and commonly used because it is quite straightforward. However, those with solitary tumors and even with portal pressure, mildly elevated portal pressure, sometimes cannot undergo transplantation in our setting because of the cost and because of other logistic issues. So this is the reason why many of the countries that are constrained by these have been challenging the BCLC. And the most recent publication from the ESMO that they have modified the BCLC and included BCLC-B liver resection as one of the strategies, and even liver transplantation in patients having 5 to 10 centimeters tumor that is incorporating the extended criteria, extended Milan criteria. So these are the new developments that is currently advocated by ESMO, provided that the liver function is preserved and patient would still have a good ECOG status. And in the low resources area like us, resection remains to be the mainstay in terms of our approach. So this is just a few of the examples showing that these are BCLC-C patients with portal vein thrombus and portal hypertension, and also multinodular tumors, even with a bilirubin, total bilirubin of a little over 1, but we still do surgeries for these patients. And also this one, pretty much the same criteria. So you see here, even when there is a portal vein thrombus in multinodular HCCs, surgery or resection can still be recommended as long as we fulfill the criteria that we have simplified in our setting, which is this particular simplified guideline. Once a patient is diagnosed with HCC, if the patient has ascites, then we stop. Nothing else is done. We offer alternative approach, send them back to hepatologist or the oncologist. If the patient doesn't have any ascites, then we subject them to endoscopy to check for esophageal varices. And if esophageal varices are present and they are moderate to severe, we stop and treat and reassess later on. But those that can fulfill criteria are those with minimal varices and bilirubin that is less than 2. So bilirubin more than 2 will also have to be reassessed and possibly consider other options, while the rest will have to be assessed whether the resection, the remnant liver volume will be good enough to fulfill this criteria. And also the decision to do it open or lap will be determined by the location of the tumors, the status of the liver functions as well. So this has been our approach and really has proved to be useful for theoretically unresectable single HCCs outside of the Milan criteria, even for multinodular HCCs and even those with microvasculobiliary invasion and even gross portal vein invasion. And if portal vein resection and reanastomosis is necessary, then we also do the same. But of course, all of these are done mostly in an open approach because to us, it's quite difficult to do it laparoscopically. We haven't gotten into the beyond that learning curve of doing the vascular resections and these approach laparoscopically. But for open, relatively, the outcomes has been not so bad, with a good 3-year survival rate of 58% and 5-year survival of 28% in all, considering all the cases. So as I mentioned, about 50% of the cases are BCLC B and C in our population of patients, and majority are male, with more than 55% of them are more than 60 years old. Majority are in Child-Pugh A, mostly hepatitis B, and these are the sizes of the tumors, and mostly the tumors are ranging between 8 to 16 centimeters. AFP, most of them have high AFPs, and 60% have mild cirrhosis, 17.5% have severe cirrhosis, 62.5% undergo right hepatectomy, and the rest are left hepatectomy. And because of the advanced stage, most of them, majority of them have lymphovascular invasion, which actually is the most significant factor in determining their overall survival. So we see that there's a big difference in patients who have vascular invasion versus those without vascular invasion in terms of the 5-year survival rate. The incidence of recurrence in these patients is 30% within 1 month, within a year, and median overall survival is 35 months. Now, comparing this with our embolization, TACE for HCC, the overall median survival is very, very poor at 8 months. And this is comparable to the data from Hong Kong as well, when they compared these patients who underwent a resection versus those who underwent HCC. Resection outperformed embolization with a 3-year survival of 51% versus 18%. So in our case, 31.6% of them developed stage progression after the first TACE. And so we label this as TACE refractory. Most of our cases are done by anatomical resection, and we employ the use of ICG to be able to map out the anatomy clearly intraoperatively, showing us the area of resection. For example, in this, the central hepatectomy was done, and so we do a negative staining and also positive staining methods. This is just to show you again another case of a huge tumor with portal vein thrombus that has gone all the way into the main portal vein, where the main portal needs to be anastomosed as well. For the comparison between an open and laparoscopic, very little, only 31% undergo laparoscopic resection because of the size and the advanced tumors. And this is the current data that we have. It is not yet updated, sorry about that, but this is what we have at the moment, with a median size of 6 centimeters. The 21 centimeters is an outlier because this is a tumor in the periphery in the left lateral, and so we thought it is easy to do it a left lateral resection, even by laparoscopy. Tumor sizes, operative time are all here, and congruent with most studies, there is less blood loss, and a longer operative time compared with the open approach, especially when we are doing large tumors as well by laparoscopy. Our largest tumor by laparoscopy is 16 centimeters by right hepatectomy, apart from the 21 centimeters that was an outlier, as I mentioned. So mostly are between 8 to 12 centimeters. Looking at the quality of life of these patients, they report, of course, they report a better well-being, overall well-being, whether it is physical, emotional, or spiritual well-being. And clearly the pain and the scar has been very much different between 30 days and 90 days comparing these two approaches. Outcomes definitely are much, much better in terms of physical health, mental health, and income assets as well. And decrease in catastrophic spending it is quite evident. So just to show you, let you see the difference in our cost between open and lap. The cost is significant, almost to 2,000 difference. And it is very significant in our case because patients have to shoulder the expenses themselves. This is out of their pocket. But the length of stay definitely can be shortened to 4, and sometimes it can go as high as 8 in cirrhotic patients and in patients with poorer functions. But the problem is the feasibility and the ease of scheduling, because we have limited operating theaters and instruments and equipments for this approach. So this is just to show you the possibility of doing laparoscopy even in with our minimal equipments that we have. It's quite challenging, but we try to do them as much as we can. Comparing with the huge tumors, it's really difficult to do it laparoscopically, and so majority of the cases, 70%, are still done in an open approach. For your curiosity, this is a patient that was operated 2 years ago with such a huge tumor. Patient is still alive, but there was a recurrence in the recent imaging. So showing the overall survival function and emotional scores, comparing the open and laparoscopic approach, it's very, very evident that laparoscopic approach is much more welcoming to these patients. Our limitations lie in that there is
Dr.
no
Tay,
direct
can I ask you to maybe wrap it up? Where I just don't want to run over too much for the other talkers, but
sorry.
the other speakers. No, that's okay. I mean, obviously these are incredible cases.
Yeah. So anyway, the limitation really is that much of our time, a lot of our times, we're doing salvage hepatectomies, and also preoperative treatments may have to be offered to these patients to be able to do a laparoscopic approach, for example, in this central hepatectomy for a 14-centimeter tumor in a cirrhotic old lady. So the results are very much in congruence with the new data that was published, where 35.7% of recurrence are detected in those beyond BCLC. So I mentioned that as well. We got a 30% recurrence rate. So using the ICG with liver mapping would definitely help laparoscopically to do more segmental resections. And safe and efficient strategy would need a multidisciplinary approach to be able to treat HCC. And the approach would be would spell out safety, because we need to determine first the status or performance of the patient in terms of the ECOG, associated the comorbidities, function of the liver, the extent of the disease, including extrahepatic metastasis as well, the treatment strategy, whether it's resection, transplantation, local, regional, or systemic, and the why is you yourself have to determine what your comfort level is in selecting whether it is an open or a laparoscopic approach. So that ends my talk. Thank you.
That was great. Thank you so much. I mean, obviously incredible cases, and your approach. I really like that simplified flow chart that you guys use. I have a few questions written down, but I want to save them to the end if we can. just so we can keep moving along. But that was really appreciate that. Hopefully we'll have some time for a couple questions at the end. So next we're going to go to Dr. Hop Tran Kao from MD Anderson in Houston, and he's going to talk about some biliary cancer.
Are you able to hear me? Okay, and you can see my screen?
Yep.
All right, perfect. All right. Well, thank you very much, Tim, and to SAGES. Thank you for inviting me to give this talk. It's an honor. I have no disclosures. So I took a little bit of a different approach to this talk than Dr. Tay. I kind of wanted to focus on the state of systemic therapy for biliary tract cancers. And so I won't be talking about surgical aspects of things. I'm happy to answer questions in the question section. But so I want to talk about chemotherapy by and large, but also touch on novel therapeutics with regards to biliary tract cancer therapy. As is often the case, right, what we use in the adjuvant setting is informed by what works in the metastatic setting. And in the case of biliary tract cancers, that's the ABC02 trial, the landmark trial that really established GEM-CIS as your standard of care for unresectable and metastatic biliary tract cancers. Now, what's been kind of remarkable about this trial is that it demonstrated a pretty consistent effect size with GEM-CIS across tumor sites, whether it be intrahepatic, extrahepatic, or gallbladder cancer. And as a natural progression of this, right, you've got clinicians asking themselves, should we be adopting this regimen in the adjuvant setting? And that question is being studied right now in the ACTICA-1 trial. And the other question is, should we turn this doublet into a triplet to potentiate this regimen for advanced cancers? So that's where the GAP trial comes into play. This is a single-arm phase 2 trial that added nab-paclitaxel or Abraxane to GEM-CIS, with the primary endpoint being progression-free survival with power calculations using a historical value of 8 months. 60 patients were included in this trial, the majority of whom had intrahepatic cholangiocarcinoma. And what you'll see is that the progression-free survival, the median progression-free survival in this study was 11.8 months, which far exceeded the expectation. And when you look at this waterfall plot, you'll see that there's an 84% disease control rate, including a 45% partial response rate, which is really quite remarkable. So the GAP trial is a positive study for advanced biliary tract cancer, showing a progression-free survival of 11.8 months compared to 8 months. And it really set the groundwork for the SWOG 1815 trial, looking at patients with metastatic or locally advanced biliary tract cancers. This is a study that just recently completed accrual and seeks to compare GAP versus GEM-CIS. And so we'll be looking for this to be reported soon. So that's the state of affairs with regards to metastatic disease. GEM-CIS as the gold standard, and then GAP as something to consider and something to think about. How about the adjuvant setting, right? I just mentioned to you that ACTICA-1 is a trial ongoing right now, recruiting across Europe, looking at GEM-CIS versus standard of care, which up to until very recently had been observation. That is until the publication of the BILCAP trial, which is one of 4 adjuvant therapy trials for resected biliary tract cancers. So I'll go briefly over these trials. The first is the SWOG 0809 trial. This is a single-arm phase 2 trial that used GEM-CAPE and then followed that with radiation, chemoradiation for patients with extrahepatic cholangiocarcinomas and gallbladder cancer. The primary endpoint was survival, and this was a favorable outcome in this trial. 2 years survival was 65%. But I think the other thing that was interesting here is that there was no difference in median survival comparing those who had positive resection margins compared to those who had negative margins. And this speaks to likely the impact, the effect of chemo and chemoradiation in particular on disease control when you have positive margins. The next 2 trials were negative trials, one out of Japan, the other out of France. The Japanese trial showed no survival benefit associated with single-agent gemcitabine compared to observation amongst 225 patients with extrahepatic cholangiocarcinoma only. And the PRODIGE 12 trial out of France used GEMOX, and there was no benefit to GEMOX compared to observation across 196 patients who had pretty broad spectrum diseases. The thing that was pretty similar about these two studies, which I think is important to note, is that they both had pretty good resection margin data. So R1 was only 11 to 15% between these two studies, and only a third of the patients had node positive disease. Now, when you compare that to the BILCAP trial, it's a big difference. The BILCAP trial had a positive resection margin rate of close to 40%, and nearly half of the patients in the study had nodal involvement. So a little bit of a different patient cohort, really. Let's dive into the BILCAP trial because it is, after all, the trial that has now determined new standard of care for adjuvant therapy for biliary tract cancers. It is a trial that enrolled 447 patients, randomized them to 1:1 to capecitabine versus observation. The primary outcome of interest is overall survival by intention to treat. It is important to note that per protocol, overall survival was an identified a priori secondary outcome. So again, high rates of R1 resection, high rates of nodal involvement. When you look at the survival data, here's really where the meat in the sandwich here. By intention to treat, you see that the median survival with capecitabine was 51 months. It was 36 months for the observation cohort. But this difference fell short of significance. But on the per protocol analysis, this did reach a significant statistical significance. So not positive by intention to treat, positive with pre-specified per protocol analysis. So the other thing to think about or to pay attention to is that when you look at the sub-disease sites, the effect size of capecitabine was not nearly as consistent as what you saw with the ABC02 trial. In particular, with hyalocholangiosis and gallbladder cancer, it's not quite clear that there truly is an advantage or not. But of course, we have to keep in mind that this study was not powered to enter site-specific data. So to recap, the BILCAP trial is a positive trial overall for biliary tract cancers, showing a 15-month effect size with capecitabine. It is underpowered for individual cancer sites. I do know that there's a lot of medical oncologists out there who are a little bit reluctant to kind of adopt this quite as a Bible for hyalocholangiosis and gallbladder cancer based on the subset analysis. Keep in mind this is a study with high rates of R1 resection, high rates of nodal positive disease, which probably underlie at least to some extent why this might have been a positive study compared to the other two negative studies. And it established capecitabine as standard of care adjuvant therapy, so much so that ACTICA-1, which I mentioned before, has now changed their control arm from observation to capecitabine. How about neoadjuvant therapy? Quite simply put, there so far has not been any well-studied trial in neoadjuvant therapy for resectable biliary tract cancers. I do want to kind of plug our study here a little bit. This is the phase 2 trial of neoadjuvant GAP, the same regimen that was discussed earlier in the metastatic setting, for patients who have resectable intrahepatic cholangiocarcinomas with high-risk features. These include T-stage 1B and above, tumor size greater than 5, multifocal tumors or satellite lesions that are confined to the same lobe, major vascular invasion, or suspicion of or established nodal disease. It is a multi-site study out of Emory. Shishir Maithil is the study TI. The endpoint is feasibility, but beyond that, certainly radiologic response, recurrence-free survival, and overall survival as well. So hopefully we'll be able to share some data in the near future, in the next year or two, about this trial. I want to shift gears a little bit. That was systemic chemotherapy. What is really important for the surgeon treating biliary tract cancers to know is this field of novel therapeutics that's emerging very rapidly, in particular molecularly targeted agents, which is changing by the day. So the genetic landscapes of biliary tract cancer has really exploded in recent years with a large number of studies that have looked into mutations in these cancers. And beyond the standard P53 KRAS SMAD4 mutations, there's a huge other number of mutations that have been identified. And what really has you can get from this is two main things. One is that this genetic landscape has confirmed to us that gallbladder cancer, extrahepatic cholangiocarcinoma, intrahepatic cholangiocarcinomas are really different diseases. They have different mutational profiles. They have different signatures. So that's important to know. The other thing is that, fortunately, there are some of these that are actually actionable targets, whether it be IDH1 mutations that we can now target through some agents against that, whether it be FGFR mutations. There are a number of agents out there that can be used against these targets. There's an ongoing batch trial looking at unresectable biliary tract cancers and use the molecular profile, the molecular mutation to then move patients down various, paths of therapy using targeted agents. How about immunotherapy? Well, cholangiocarcinomas and bile duct cancers in general are just not really highly immunogenic tumors. You'll see that the mutational burden is pretty low for these tumors, and the rate of MSI high, which we know to kind of suggest the efficacy with immunotherapy, is really low at 1%. It is a low mutational burden cancer, higher in Asian patients, which might suggest a role in hepatitis B or parasites, causing this mutational burden to be higher. The responses that we've noted so far, that have been noted so far with single agent immunotherapy with Pembro, for instance, has been really disappointing. There's ongoing trials looking at combination immunotherapy or therapy with immunotherapy combined with chemotherapy. So that should give us some more information. So in conclusion for my talk, really, capecitabine is now the standard of care adjuvant therapy for biliary tract cancers. The role of neoadjuvant therapy is still being explored. The somatic mutation profiling combined with novel therapeutics and multidisciplinary care of BTCs are truly altering the disease trajectory of this disease or this group of diseases. Sequencing should be obtained for all biliary tract cancers. I think that is an important area that we need to pay attention to as surgeons. Immunotherapy's role is still being defined. And importantly for all of us, these agents, while currently not quite in our field yet and currently investigate for advanced unresectable disease, will soon make their way into the management of resectable diseases. So just keep an eye on that. So with that being said, I will close my talk and I'll take questions at the end. Thanks.
Thanks, Hop. That was great. We have a couple minutes for questions before we move on to the next one. So I had a couple questions. So you're sequencing all patients? Is that upfront? You're getting sequencing on everybody, or is it just in the metastatic setting that you get it upfront, or patients who have, node positive, things like that, or everybody right away gets sequenced?
Yeah, so right now, clearly all patients with metastatic unresectable disease are getting sequenced. We are, as a group, trying to standardize getting sequencing for all patients who have, tissue. So after you resect them, we do try to sequence them as well, because we know the recurrence rate for these tumors is not low. It does, and so getting this information will be important. And I think as we pave the way moving forward to see how these agents might be used in the adjuvant setting potentially, or even neoadjuvant setting, it's important to collect as much data as we can right now.
Sure. And then just to kind of simplify a bit in the adjuvant setting, the data is so confusing around these biliary tract cancers. Sure. Are you really using CAPE as your kind of go-to for everybody, or are you treating node negative the same as node positive, or using multi-agent for node positive, or kind of what's your simple approach to, let's say, a gallbladder cancer that a node negative gallbladder cancer versus a node positive? Are you treating them differently? Let's start with that.
Yeah, so I will tell you that there's, of course, the practice depends on the medical oncologist, and it is a multidisciplinary kind of effort. I refer all my patients to get resected intrahepatic cholangiomas, extrahepatic cholangiomas, gallbladder cancer to medical oncology, regardless of whether they're node positive or not, whether they're margin positive or not, right? all of them get referred to the medical oncologist for conversation and discussion. We don't have the granularity right now to tell us what subset of patients, whether it's N1 or N0, whether it's, you know, margin positive only, whether it's certain size criterion, that should dictate getting capecitabine or something else, right? So I think by and large, in patients who are, what I've seen or what we've kind of been aggressive about, in patients who are young, who have good performance status, we're aggressive with them, right? So we will propose by, you know, capecitabine. I will say for gallbladder cancers, for high-local there is a little bit of bias towards GemCis still at the institution. You know, whether that's warranted or not, we'll see. Actica 1 will tell us, right? But I think for everyone, we do consider chemotherapy. We do consider some systemic therapy.
Yeah. Yeah. I think trying to figure this stuff out, reading the data, it's all very confusing what the exact right answer is. And then just a final question. Outside of trial setting right now, are you guys doing neoadjuvant for biliary tract, and what is your criteria to get there? Are you using the same criteria as the trial you referenced, or?
Yeah, you know, I will be honest and tell you there are patients, you know, whom you see who have, so let's define one thing, right? Resectable neoadjuvant really is in the context of resectable disease, you know, anatomically resectable disease. I'm not talking about the borderline resectable or those that have advanced features, right? Or anatomic constraints. But there are patients who, akin to on the pancreatic side, where you have, you know, physiologic unresectable or borderline resectable, you have patients who have, let's say, you know, relatively unhealthy, right? You know, comorbid conditions are high, or who have biologically concerning features, whether it be a really high CA19-9 and large lymph nodes. Those are patients in whom we are considering neoadjuvant therapy. It is not based on the protocol necessarily. Well, now we're enrolling them into the, you know, the GAP trial. But previously, even those patients, we would kind of think about giving GemCis ahead of time. But now we are trying to enroll them all into the GAP trial when we can.
Okay, perfect. All right, well, thank you very much. That was a good prelude to the next talk, which will be on pancreas cancer with Dr. Kubi, and he'll try to cover the very controversial topic of when to use neoadjuvant in pancreas cancer. So Dr. Kubi, with that segue, take it away.
Can you guys hear me? And can you see, well, let's see if my slides come up.
Yep, screen looks good. We can hear you. Excellent.
Thank you, Dr. Vreeland, for this very kind invitation to the SAGES. Great society, and an honor to be part of it. So tasked with giving a talk on pancreatic cancer, sort of current surgical management in 2020 in roughly 15 minutes. And it's one of those topics that 10 years ago, I could have given the talk in 5 minutes because it was either operate or don't. But now we actually have some data, and we have some better understanding of the disease. We've not made a lot of progress, but we're starting to see some small steps in the right direction. So quick plug for my institution, Emory University Hospital right here. That's the University Hospital. Let's see if I can get the cursor in the right place. This is St. Joseph's Hospital, where I'm the chief of surgery. Great hospital as well, is where I do all my pancreatic resections, and then the medical school. So in the next 15 minutes roughly, I'd like to spend a couple minutes on defining borderline resectable pancreatic cancer, move on to this, really the crux of the discussion about adjuvant versus preoperative therapy, what to do with that. And then Dr. Vreeland kind of tipped me off that I might get asked questions about surgical margins given publication of a recent paper out of Mass General in Verona. So I took some liberties to kind of look at that paper and compare it with the data, compare and contrast it with the data from what we've previously published through our clinical research group. So
Dr. Kubi, real quick, I think your slides are frozen.
Oh, really?
Yeah, or maybe you're not. I can't tell. Maybe you're not sharing the correct screen, or
let me see.
We're still on your intro slide.
Oh, I had moved on, so let me see if I can fix that.
Yeah, that looks better.
So that's not in presentation mode, though. Let's see if we can fix that. I will see if I can stop sharing, and I'll try to share again. Tell me if this works better. Do you see the overview?
We're still seeing not in presentation mode, just a regular mode.
Sharing is paused. Bring your shared window to the front. Hold on one second. Let me see if I can figure this out. Let me try this.
Might be a multiple monitor issue.
Yeah, that's exactly what it is.
Yeah.
All right. Do you see the slides now?
Yeah, I see all your slides still, and your arrow's in there, your cursor's in there. So
let me do this. Stop share. Let's try one more time. Sorry, I did have a couple monitors.
No, that's okay.
And show. Here.
Tamara Floyd says hit Alt Tab. Maybe that'll switch screens.
So there's no Alt on a Mac, is there?
I don't think so.
Let's try this. Let's see. I disconnected my other monitor.
Oh, okay.
And let me go into presentation mode and see if it works this way now.
Yeah, that looks good.
Okay. You see Emery?
Yep.
Okay.
Yep. That looks good.
So three areas that I wanted to concentrate on. One was definition of borderline resectable pancreatic cancer. Spend 2 minutes just defining it because it's relevant to the discussion about adjuvant versus preoperative therapy, which is the second topic. And then since Dr. Vreeland tipped me off that I might get asked questions about surgical margins, we'll try to tackle that if we have time. So here's an axial CT showing the typical hypodense mass in the head of the pancreas, the main SMV and the SMA vessels that we deal with in the operating room. And you can see the stent shown in white. And then if you were in a little car, you could drive right through them because there's a fat plane separating the tumor from the vessels. And this would be defined as a resectable tumor. So if you take this scenario where now you can see the SMV is clearly engulfed in tumor, and you try to drive that car between the space, you don't have that fat plane, and this would fall into the category of borderline. However, there are multiple definitions for borderline because very vague terms are used, such as abutment. Here you see the vein and a tumor where the tumor is up against the vein. Here you see an artery, in this case the SMA, which is actually deformed as sort of a teardrop with tumor around it. This is, the vague term impingement is sometimes used. And then sometimes you'll see this target sign with tumor surrounding a vessel, in this case, the SMA, and sometimes they'll use the term encasement. So if you look at a summary of all the different types of definitions of borderline resectable pancreatic cancer, really, which, more than 15 years ago wasn't even a thing, by definition, then you see here the MD Anderson definition, the HPVA, and the NCCN had multiple definitions. You see all the key vessels of interest, the SMV, portal vein, SMA, common hepatic artery, and celiac, and then you see all these same vague terms. You see occlusion, abutment, encasement, impingement, and narrowing. And it's very hard to really compare apples to apples when you're doing clinical trials or discussing cases, for potential treatment, if you don't have a reproducible definition. So the Alliance, which is the clinical trials group that essentially combined ACOSOG with CALGB, came up with a definition in 2013 that they've been using for their clinical trials, and they've switched to the term interface. And this is really a valuable term that is reproducible, that we have discussed with our radiologist, and in their reports they use the term interface to sort of define how much of the vessel and which vessel is involved by tumor, and therefore we now can speak the same language, and this is helpful. So when you take a case such as this, here is 2 coronal cuts of a CT scan of the same patient showing a hypodense mass in the head extending to the neck of the pancreas. You see an enlarged pancreatic duct. And in this case, you see that there is an interface with the portal vein and SMV. And, you know, one could argue that this could be considered resectable because the vessel is not actually invaded, and probably you could get this off without having to take the vein. But at the same time, another person might look at this and call this borderline. And based on the fact that there's an interface that is roughly 180 degrees, we would call this a borderline resectable tumor. So why is this important? Well, we know pancreatic cancer is a miserable disease, and in the early 1980s through 2000s, we haven't made a lot of progress with this disease, and we know the definition of insanity is doing the same thing over and over again and expecting a different result. So resection alone is not the answer. If you look back to 1987, there was the Gitzig trial, which showed that 5-fluorouracil-based chemotherapy and radiation resulted in a better survival for patients who just had resection alone. But it was a poorly done trial, underpowered, and most people didn't put a lot of stock in there. When I finished my training at Memorial Sloan Kettering, Dr. Brennan, who was our chair at the time, was very keen to say, as of right now, the standard of care is surgery for resectable pancreatic cancer. And he wouldn't even send his patients in referral to oncologists for consideration of adjuvant therapy. Well, that's changed in the early 2000s, the publication of the SPAC1 trial, which was a complex trial, not easy to clarify. Basically had 4 different categories. You either got resection alone, or resection with adjuvant chemo, resection with adjuvant chemo and radiation. And so then the patients also crossed over. So very confusing, but the bottom line that came out is if you received chemotherapy after resection, you did better than if you did not receive chemotherapy. But the patients who received chemotherapy and radiation, or radiation in any form, did worse than patients who didn't even get chemotherapy. So confusing, but in Europe, the standard became adjuvant chemotherapy only. And in the United States, people were still giving chemotherapy and radiation. I won't go through an exhaustive list of trials, but I'm really trying to give the key ones that you should have in your back pocket when you think about this disease. Then in 2013, the CONCO trial, which is a German trial, compared adjuvant gemcitabine to resection alone, or observation, that is. And you can see on the right side of the screen that the group that got the adjuvant gemcitabine did significantly better than the patients who received observation alone after resection. And this truly shaped the standard of care to receiving adjuvant chemotherapy after surgery. Well, better chemotherapy has come up since then. We have FOLFIRINOX and nab-paclitaxel, or Abraxane, which both these trials were published in the New England Journal of Medicine at the same time. FOLFIRINOX is the more toxic regimen, but had a enhanced overall survival for patients with metastatic or locally advanced unresectable disease, 11 months versus 7 months, where the Abraxane over standard gemcitabine chemotherapy had a roughly 2-month survival advantage, but was better tolerated. So basically, we've extrapolated now that we use one of these 2 regimens based on what a patient could potentially handle. And then most recently in 2018, there was the PRODIGE 24 study, which looked at adjuvant FOLFIRINOX in extremely well-selected patients. And this was a positive trial, which showed that receiving this modified FOLFIRINOX resulted in an overall survival benefit, quite astounding actually, 54 months versus 30 months for gemcitabine. But it tells you that if the gemcitabine arm survived 30 months, that this was a select group of patients. And so whether this is translatable to every patient we treat is still questionable. So when we think about whether we should give chemotherapy before or after, well, the theoretical benefit of giving preoperative chemotherapy is it allows more patients to receive chemotherapy, because after Whipple, many patients are not good enough shape to receive it. Second, it potentially provides an in vivo treatment response assay. If the tumor responds, well, if we're going to give more chemo afterwards, then we see a response pre-op, we're more likely to give the same chemo after. Third, it might enhance our patient selection. If a patient progresses on chemotherapy when we give it in the preoperative setting, we're unlikely to take them to surgery. And finally, it might improve our margin negative resection rate by reducing tumor volume. The downsides potentially of preoperative therapy is it's a long timeline. So this would be a standard timeline. You get a staging CT and assess the patient. They'd get 2 months of chemotherapy, they'd be restaged, another 2 months of chemotherapy, restaged, and maybe chemoradiotherapy, and then restaged again. And by then it's 6 months. And this is a 6-month delay to surgery. It's a crude assessment of tumor biology. It has logistical concerns. Some patients just really can't go through all this before they get to surgery. And there are also psychosocial concerns. Many patients are really overwhelmed with concerns of progression of tumor prior to actual getting to surgery. So then how does it stack up, giving adjuvant therapy, after resection versus doing chemotherapy and or radiation prior to surgery? Well, these are some of the early trials that I mentioned, and if you kind of give a gestalt look at them and look at their survival, it comes to about 20 months. If you look at most of the existing studies on preoperative therapy, right, so giving it before, and you add these all up, guess what? It comes to about 20 months. Not a lot of difference. So it makes you scratch your head, really, what is the best approach? And then if we're going to do it in the preoperative setting, should we really be giving gemcitabine or 5-fluorouracil, or should we look to one of these other agents like FOLFIRINOX or gemabraxane, which we mentioned before? Well, there is a study that completed, and we were waiting on results on the SWOG 1505 trial. And this looked at resectable pancreatic cancer patients. They were randomized to receive FOLFIRINOX versus gemabraxane, restaged, and then off to surgery, followed by some additional chemotherapy. It is a trial that we were waiting on the results on, and during Dr. Tay's talk, I got a text from Sy Ahmad, who's one of the authors of the trial, saying it has now resulted and it's in print in ASCO. So here's the result. This literally came through in the past hour. So the conclusion of this study, looking at comparison of pre-op FOLFIRINOX versus gemabraxane, 2-year overall survival, 41%, median survival of 22 months with FOLFIRINOX versus 23 months with gemabraxane for all eligible patients starting treatment for resectable pancreatic cancer. The safety was essentially the same between the two groups, and ultimately the conclusion is there's little evidence that either regimen improves overall survival compared with historical standard controls. And again, if you look at the survival, it's 20 months, 23 months, 22 months in both arms. And so we were hoping to see much better results with one of these two agents. And unfortunately, we haven't made a lot of progress there. But this just literally got put in publication in abstract form today. There's another trial that resulted recently. This is the pre-op PANC trial. This is out of the Netherlands. And so this is the other randomized trial of pre-op therapy. 246 patients were randomized to surgery plus gemcitabine, surgery followed by gemcitabine, or gem-RT with gem followed by surgery and gem again. So this was giving pre-op therapy with gemcitabine and radiation therapy versus surgery first. So again, not FOLFIRINOX or gemabraxane, but a pre-op therapy trial. And overall, this is a negative trial. If you look at the patients who received preoperative chemoradiotherapy versus the patients who received surgery first, it did not reach a significant difference in overall survival. However, in a subset analysis of patients either with resectable or borderline resectable pancreatic cancer, there was a significant survival advantage for patients who received preoperative chemoradiotherapy, suggesting that a subset of patients might benefit from a preoperative approach in particular. So confusing data. I think at this point we say chemotherapy is beneficial. I think standard of care is still adjuvant chemotherapy. However, are all of us doing exactly that, or are some of us doing some things differently? So I took a straw poll of some experts. So 16 experts, you'll see their names. I included myself on there. And if you can see the list, I'm sure you'll recognize some of the names of some of the pundits in pancreatic surgery. And so here are the questions, 3 questions, very simple. I asked number 1, healthy 67-year-old, 2.5 centimeter pancreatic head cancer, no obvious vessel interface, therefore resectable. And I gave them 4 choices. Would you do chemotherapy only upfront, or chemotherapy and radiation followed by surgery? Or would you go straight to the operating room for Whipple and give adjuvant chemotherapy only? Or would you go straight to the OR, do the Whipple, and give adjuvant chemotherapy and radiation? And here's the result we got. The majority, even though I've explained to you that adjuvant chemotherapy is still our standard of care, the majority wanted to give preoperative chemo. The majority, the second majority was adjuvant chemo, and only 1 responded giving pre-op chemo and radiation for all their patients. Second question was the same patient, but in this time it's a borderline resectable case. There is an interface with the portal vein and SMV. Same 4 choices: chemo up front, chemo radiation up front, or surgery first followed by chemo, surgery first followed by chemo radiation. And here, there were only 2 choices. Everybody wanted to give, the majority wanted to give chemotherapy in the adjuvant setting, and a few wanted to give routinely chemotherapy and radiation. So then I asked the third question, which is, what statement is most consistent with your approach to recommending radiation therapy for your patients with potentially resectable pancreatic cancer? And there were 6 choices. One was, I think all patients who undergo resection for pancreatic cancer should have radiation as part of their treatment. The second is, I recommend radiation therapy for pancreatic cancer patients with any radiologic venous interface. And again, I was leaving out the arterial interfaces. Third is, I recommend radiation therapy for pancreatic cancer patients who have persistent radiologic venous interface after preoperative chemotherapy. Fourth is, I try to avoid radiation for my pancreas cancer patients unless there's a positive margin. Choice 5 was choices 3 and 4 combined, meaning persistent venous involvement or positive margin. And the last was number 6, which is, I discourage use of radiation for all pancreatic cancer patients. Very controversial topic. And here is the response. So I gave 6 choices. I got 5 different answers, with the most common one being choice 5, which was the majority who answered with 1 choice was that they would use radiation if there was a persistent venous interface or if they had a positive margin. So clearly we do not have a standard of care for radiation therapy.
Dr. Kuby, what was your answer to that question? I'm curious how you answered.
The reason I created a choice 5 was because that was how I felt about it. And it was interesting to see that others felt the same way.
Yeah.
And you know, when you ask this group of experts these questions, you don't just get A, B, and C responses. You get diatribes of that. Well, you know, I do this and that, and there's this, and So bottom line is, we just don't have a standard for radiation therapy, and we don't necessarily follow the standard for chemotherapy. So how can what can I conclude about this? So adjuvant therapy still remains the standard of care for resectable pancreatic cancer. And for those patients who can tolerate it, I would say it's FOLFIRINOX. If not, either GEM or Xeloda single agent or a combination. I think this is where we have the best existing data. I think we have lower psychological and logistical hurdles for some of these patients. There's a higher therapeutic compliance rate because most patients want to go to surgery if they can tolerate it. We have a reduced risk of postoperative complications, and this is widely accepted by patients and docs. The preoperative therapy strategy for resectable pancreatic cancer is a promising strategy. We have emerging data. This is the one now we have 2 randomized controlled trials as of today. There is greater psychological and logistical hurdles that we have to encounter. We have potentially a lower therapeutic compliance and potentially increased complications, but it is gaining some acceptance into practice. So what's our approach? Well, we have a team. And so this is our team, all the components of our team. This is an old picture. There are different members of our team now, but it's still a nice picture. And I enjoy this one where all the pundits are sitting around the table. That's where all the attendings are. And notice they all have their hands up to their face in deep contemplation of a case being presented by Art Disek, our outstanding body radiologist who handles a lot of these cases. I don't know if I've gone beyond my time. I had the topic on margins for pancreatic cancer. Tim, tell me what you want me to do.
Yeah, so I think Tim got disconnected. He texted me. So he would like for Dr. Clary to get going at 7:40. So
Okay.
let's wrap up your talk and let's have Sean get started.
So my talk's wrapped up. I'll stop there. Let's have Sean talk, and if there's questions about it later, I'm happy to discuss it.
Perfect.
Thank you, guys.
Thank you.
All right. Well, can you? Thanks very much, Hop, and to David Kuby. It's an honor to go after those two individuals. Let me just make sure that I've had a slightly unstable internet connection, so I apologize in advance for anyone who is, if I get cut off. So again, thank you very much to Sages, to Tim Vreeland, to Kevin L. Hayek, and to the Catherine, David, and Hop for going before me. It's an honor to be involved. And much like David said, it's almost impossible to compress a topic in which you could spend hours discussing into 10 or 15 minutes. But I will try and provide at least an update and an evidence-based update into some of the relevant issues in colorectal cancer, liver metastasis. This is a relatively common disease. I think that most of us, no matter where we are in the world, deal with colorectal liver metastasis. Certainly for North American centers, it's much more common than some of the other diseases. Can develop in about 30% of all patients diagnosed with colorectal cancer. About half of the metastasis will be diagnosed synchronously. And obviously, I think as colorectal cancer is multimodal, it really requires not just careful and thoughtful surgical planning, but also multimodality therapy planning. And again, I think we sometimes forget because we've been so immersed in multimodality therapy that the life before liver resection and chemotherapy was pretty grim, with a 5 to 10% overall 5-year survival left untreated. And yet still, when we look at data across the US and North America, and I'm sure other areas of the world, surgery is still vastly underutilized for patients. Too many patients are not considered surgical candidates, and therefore certainly it's imperative upon us to spread the word about this disease and to encourage medical oncologists and gastroenterologists to refer these patients, even whether they're synchronous or multifocal. I always tell our trainees that my least favorite phrase in radiology is innumerable liver metastasis, because that ranges anywhere from 3 to 25, and hopefully most radiologists can count above 4. So there's been certainly an evolution in this disease. We used to talk about when early in my training about what came out. We counted metastasis, we measured them, and certain surgeons had cut off that they take out 2 mets or 3 mets, but never 6. And that was a relatively easy thing for people designing trials and people writing papers to define. And now it becomes much more difficult to define, in that now we talk about resectability not being defined by the number of lesions or the size or the lobe that they're in, but we're more defining it about not what we're taking out, but what we're leaving behind. In other words, can we resect all of the disease with an adequate and functional future liver remnant? And that is certainly much more difficult to define. And certainly people lose a lot of sleep trying to write trials that define resectability in colorectal liver metastasis. And certainly there have been attempts, but really I think we come down to these vague definitions that if Resectability is based on ability to achieve an R0 margin, or even now an R1 in certain circumstances, with adequate remaining future liver remnant volume in parenchyma, and leaving a remnant with adequate vascular inflow and outflow and biliary outflow. So again, that becomes much more difficult to define and converse in a simple thing. The other thing that's certainly changed in this disease is chemotherapy. And I think we surgeons would like to take a ton of credit for the advances, but really we have to share that credit with the medical oncologists. And you can see that the number of patients undergoing liver resection and the outcome for patients over the years, certainly within the last 20 years. And that has been in large part not only to advancing techniques and aggressiveness in surgical therapy, but the introduction of chemotherapy and biologics. And so our opportunities and options in selecting systemic therapy is certainly extremely broad now. Again, so what we used to talk about in terms of number and size of lesions was described well in the classic Fong paper in 1999 of 1,001 liver resections from Memorial Sloan Kettering. But now we're talking about, again, not just resectability, but also in terms of the response of lesions to chemotherapy. And so this has really trumped any sort of measuring or size the number of lesions. And as you can see, as we've introduced new agents to chemotherapy, we've improved our progression-free and overall survival. So now with multi-agent chemotherapy, we're really seeing significant improvements in overall and progression-free survival. This has become even more complex in the last several years as we've come to appreciate the genetic diversity of colon cancer, not only between individuals, but across the actual locations. And you can see that we have really definitions of left-sided and right-sided colon cancers, and not only that differ by their mutational profile, but also their response to systemic therapy. And you can see the various pathways that can exist on the right side of the colon and the left colon. So now that these are significantly influencing the choice of chemotherapy being given in first-line therapy based on evidence. And again, this is showing up in our clinics these days. And obviously, each of these pathways, the serrated right-sided pathway and the left-sided conventional pathway, have their familial components as well, again, that influence the selection of chemotherapeutic agents. And obviously, I think one of the mutations that get the most attention, certainly, and now with widespread availability of genetic testing for tumors, is KRAS mutation status. And certainly Dr. Tran's institution of MD Anderson has led a lot of the data around the impact of KRAS mutation on outcomes after resection of colorectal liver metastasis. We talk about this, but one of the things I caution people is that we actually don't know what whether to deny people surgery based on this mutation status. We know it's a prognostic factor, but again, we haven't been able to go back and actually determine whether there are actually patients, but not answer that definitively. So we really are getting into a very complicated decision tree in terms of not just selection of chemotherapy, but the sequencing of therapy based on patient and tumor characteristics, and then extending that into molecular characteristics. And again, not forgetting patient preference, because again, this is metastatic disease. And while we've made significant contributions, this is an incurable situation for many patients. Again, we see this sort of tailoring of therapy based on mutational profile and tumor location. This was a sub-analysis of the CALGB-SWOG trial that really showed improvement in left-sided lesions with bevacizumab and, right-sided lesions with bevacizumab and right-sided lesions with bevacizumab and left-sided lesions with cetuximab, showing again that we'll use different biologics based on the location of the tumor and its underlying molecular features. Another regimen that's, I think, gained increasing popularity and is becoming increasingly used by medical oncologists, particularly in young patients, are where patients may not be resectable at initial diagnosis, but there's a possibility of becoming resectable, is really throwing all your eggs into the basket and not going for triplet chemotherapy, but quadruplet, and looking at FOLFOXIRI, which is a combination of oxaliplatin, irinotecan, and 5-FU. This is a slightly different dosing regimen than the FOLFIRINOX regimen used in pancreatic cancer, so you can't just flip the same regimen over. And then again, now there are studies combining FOLFOXIRI with biologic therapy. But what we've seen here is significant improvements in overall response rates and resection rates using FOLFOXIRI over traditional FOLFOX or FOLFOXIRI or FOLFIRI regimens. And I think that again, this is a slightly more toxic regimen, but for young patients, and particularly patients where you need a bit of downsizing with your chemotherapy, this can be a very attractive regimen. Obviously, this has all been built on the premise that neoadjuvant chemotherapy or chemotherapy delivered before liver resection has become essentially standard of care. But I think it's important to remember that there really is not a ton of evidence supporting this. Again, we go back to the EORTC trial where this was randomized a trial of patients with resectable colorectal liver metastasis alone. And again, this was only statistically significant in progression-free survival in patients that received liver resection. So an intention to treat, this did not achieve the pre-specified endpoints. So while I think it's widely practiced and I think we use it extensively, it's important to remember that the actual level 1 evidence behind this is still quite thin. A little bit more up-to-date information again, and I think this surprised many of us, was this follow-up to that, which was the new EPOCH trial, which was the use of a biologic cetuximab, which is an EGFR inhibitor, that was combined with either a FOLFOX or FOLFIRI backbone. So you compared chemotherapy to chemotherapy plus cetuximab. The backbone was at the selection at the discretion of the medical oncologist. And I think that this was a shock to many people to find that actually cetuximab was not only equivalent, but potentially harmful in this patient population. And again, this was a patient population selected for KRAS wild type status. So they had already selected people who were expected to benefit from the addition of cetuximab. So again, I think fairly surprising results. It just goes to show that old paradigm of being able to move chemotherapy regimens from the palliative setting to the neoadjuvant setting and adjuvant setting as sort of a natural progression of chemotherapy regimens really doesn't apply now. And we need to think in terms of treating grossly metastatic disease versus micrometastatic disease. There was an update to the new EPOCH trial just this year, again, confirming the harm of cetuximab in this group in the overall survival. But what was interesting in the longer term analysis, the difference in progression-free survival lost statistical significance. But I think it still reaffirms that the findings of the initial publication were not necessarily a fluke or a statistical anomaly, but they really had some durable results. This being SAGES, we obviously have to talk about laparoscopic resection for colorectal liver metastasis. We've killed a lot of trees doing single-centered, non-systematic comparisons, as well as systematic reviews. But I think that we really have to acknowledge our Norwegian colleagues, Bjorn Edwind and Asmund Fretland, for completing the Oslo COMET randomized trial. And I think this was really a huge accomplishment for a single-centered randomized trial. So this group looked at patients from February 2012 to January 2016. So randomized 280 patients in a single center in 4 years. These patients all had resectable liver metastasis, and they defined resectable for this population as less than 3 consecutive segments, and they applied a parenchymal preserving approach. Again, this was not all comers, this was a select population, but they compared laparoscopic and open resection. They compared 147 open resections with 133 laparoscopic resections. Their primary outcome was 30-day complications. Then they defined that as greater than accordion level 2, and looked at a number of secondary outcomes, including length of stay, cost, margins, blood loss, and operative time. This, again, I think was a huge undertaking by a single center. They randomized 280 patients, again, had very good compliance in this study, and were able to analyze 144 and 129 out of those. All of the fallout was very reasonable, basically based on the finding of unresectable disease or extrahepatic disease. And really, this was sort of their baseline characteristics based on intention to treat that were fairly well balanced. Again, this was a select population, so their median number of metastasis was just over 1. They had, again, 60% synchronous disease, which I think was fairly representative of the overall population. And about 70% of these patients received chemotherapy before surgery. So again, not everybody that has colorectal, it's not meant to be representative of everyone with metastases, but certainly a population where we would think laparoscopic approach would be certainly reasonable. And their results were actually quite encouraging, and I think quite realistic. So they demonstrated that their risk of 30-day complications, and that included outside the hospital because they followed these patients very closely, was lower in the laparoscopic group compared to open, 31% compared to 19%. There was slightly lower severity of complications in the laparoscopic group. I think the interesting thing in this study was that blood loss was slightly higher in the laparoscopic group. We've been used to seeing data where blood loss is lower with laparoscopy, and so I think that's interesting in a prospective trial to see that kind of data. Their conversion rates, again, were quite low at 2% and 5% for open and hand-assisted conversions. But I think the rest of it was fairly good. Again, their margin negative rate was quite good, with only a 6 and 7% margin positivity rate. So again, showing quite skilled both open and laparoscopic surgery. Looking at the cost data that they had, they really demonstrated, I think, what we all know, and I think what Catherine showed earlier, which was the endoscopic surgery, but that these costs basically equaled out after you included the decreased length of stay. And they showed that quality of life was slightly better in the short term, but started to equal out as they got further away from surgery. Certainly looking at other modalities, and certainly ones that are gaining fairly quick acceptance across the United States, is the use of yttrium Y90 or internal radiotherapy. This, again, I've seen an increasing number of patients that have been treated with this, even surprisingly with resectable disease. I think it's important to remember that there have been 3 very large international randomized trials looking at the addition of Y90 to systemic therapy for colorectal liver metastases, and these have been utterly and completely negative. All of the individual analyses and combined analyses have been negative. The only positive outcome has been in liver-specific progression. So there may be an opportunity to use yttrium-90 in the second line setting, or in patients with liver-only disease that is not amenable to surgical resection. Certainly the hot topic in the HPV community for the last kind of 5 or 6 years has been ALPS. We saw the publication of the LIGRO trial, which was a randomized trial of 2-stage hepatectomy versus ALPS. And this was, again, fairly significant accomplishment in randomizing 50 patients to each arm. The definition for this was resectable liver metastases that required either a 2-stage liver resection or ALPS, that had a future liver remnant of less than 30%. They did allow extrahepatic disease, which I think was a criticism of this trial. And the requirement, however, though, I think that was very reasonable to suggest what that patients needed to have either stable or partial response of disease on chemotherapy before resection. Again, they randomized 100 patients and 50 were analyzed in the overall final analysis. 12 patients crossed over from the 2-stage hepatectomy to the ALPS group because of failure to hypertrophy after portal vein embolization. And what they were able to show was that an improvement in the resection rate with ALPS, as obviously a number of patients did not progress to the 2nd-stage hepatectomy due to either failure or hypertrophy or progression of disease. They saw more hypertrophy and faster hypertrophy in the ALPS group, and relatively similar in this trial, because there had been certainly a lot of criticism about the complication rates with ALPS that had been previously published. 90-day mortality rates were still, again, I think slightly higher than one would expect for this population, but again, 6.1 in the 2-stage hepatectomy would certainly be consistent with existing literature. Slightly higher mortality in the ALPS group, but again, not statistically significant. And again, margin negativity rates were a little bit lower than one would hope to see in this type of a series. There are now modifications of ALPS coming out, particularly using other techniques other than surgical and transection as their first stage. This was the Rebirth trial, which is again a randomized trial of portal vein embolization versus ALPS with rather than transecting the liver using radiofrequency ablation. There's also papers out there using microwave ablation just in terms of dividing the liver parenchyma and dividing the intrahepatic portal collaterals to induce appropriate levels of hypertrophy. As we said, about 50% of patients will present with synchronous disease, and certainly lots of multidisciplinary discussions center around the sequencing of therapy. And we've seen the traditional approach of resecting your primary disease first, followed by resection of the liver disease, has been traditionally what we've practiced. We've seen the emergence in the advocacy of the liver first approach, because the feeling that patients would really die from their metastatic disease rather than local progression, and the desire to resect the liver disease, particularly in patients with rectal cancer who may require chemoradiotherapy. And obviously in centers that are appropriately equipped and the patients that can tolerate such a procedure, an emergence of the use of combined liver and colon resection or rectal resection. Two papers that really looked at this quite well, Skye Mayo's paper and Rebecca Snyder's paper. Skye looked at 4 institutions. Rebecca looked at the ACS NISQIP data. And I think the nice summary of all of this is that equivalent outcomes are attained regardless of what approach you take. So really, I think you have to use an individualized approach based on the liver surgery and the primary surgery required for each patient, as well as the ability to coordinate such procedures at your institution. Finally, I think I wanted to just address ablation, because again, that's something that is fairly widely practiced in many centers. And I think that this it's a difficult topic to cover because there's not very good comparative data. As the data by about 1,000 to 1. Looking at various systematic reviews are often tainted by who publishes them, whether it's surgeons or radiologists or surgeons who do ablations. I think that some of the consensus opinions have been somewhat helpful. Again, this was a review done not too long ago that when you look at the retrospective data, there's about 1,600 patients in a combination of 15 case series with more than 50 patients in them. Again, the literature is dotted by a number of case series with very small patient numbers. Again, the case selection has been difficult, led to some difficulties interpreting these, in that some may have included patients with resectable disease, some may have included a combination of RFA and resection, and many patients were included in these series with extrahepatic disease. But when you look at sort of the overall summary statistics, you can look at patients treated with ablation is having a 3-year survival rate of 50% and 5-year of 31%, which is pretty good, I would say. It's slightly lower than what we've seen for resection. And when you look at the local recurrence rates, this is where people sort of criticize ablation in terms of the technique. Again, we see local recurrence rates in open ablation at between 7 and 60%, percutaneous from 10 to 52%. And traditionally, we've trotted out numbers around 2 to 6% for resection, although I think this underestimates the actual number. But certainly, I think, again, these are very wide estimates in terms of local recurrence. But I think what we find here is that really the underlying factor that probably is a significant determinant here is the size of the lesion, that really very low recurrence rates can be seen for small lesions. And as the lesion size increases, so does your local recurrence rate. Again, some of this data coming from out of MD Anderson, this is a fairly older paper, but certainly showed that patients treated with resection had better outcomes than patients treated with RFA and resection or RFA only. But I think it's quite clear, even from reading this paper, that these are different populations of patients. That in this center, if you could undergo resection, you underwent resection, and RFA was used as an adjunct for patients that could not have all of their disease cleared by resection alone. There is one phase 2 study, again, comparing RFA plus chemotherapy to chemotherapy alone. And I think that this is actually done as a very reasonably structured prospective study in Europe. And what it does show, at least, is that the combination of RFA with chemotherapy is probably better than chemotherapy alone. So there's obviously some therapeutic benefit in nothing at all with a backbone of chemotherapy. Again, these were fairly aggressive ablations. They would ablate up to 10 lesions as long as they were less than 4 centimeters in size. But unfortunately, other comparative data, including randomized controlled trials, have been very difficult. A couple have closed early. You can see the US had a study that was never published and closed because of non-accrual. There was a French study that, again, closed because of non-accrual. The clock study was downgraded to a phase 2 trial because of slow accrual. And again, we've not really seen convincing data. And other further trials, this is one just published this year, the LAVA trial has closed now to non-accrual. So again, I think we're still frustrated in answering this question in how to properly use ablation as an adjunct to surgical therapy, because there certainly is no equivalence data to show that it's similar in outcomes to resection. So for resectable lesions and surgical extirpation still remains the standard of care. With that, I'll thank you. Again, it's been a pleasure to be involved in this. It's great to see everyone. I hope everyone is safe and well. And thank you again to the speakers and the attendees. It's been a great event to be part of.
Thank you, Dr. Cleary. That was great. Obviously, a lot to cover. So we've run well over our time at this point. There has been a demand to see Dr. Kuby's slides on margins. Since we still have the Zoom account, if Dr. Kuby, if you want to do a couple minutes just giving us the bottom line of that, I think the viewers would love it. Dr. Cleary, while we're switching over slides, one question, obviously you covered a ton there. Are you using pre-op Avastin, and when are you using it?
Yeah, great question. Yes, we are using pre-op Avastin, particularly if there's a question of whether the patient will proceed to resection. But we're certainly using it cautiously and holding it for at least 6 weeks prior to proceeding with resection. I don't think we have data that the addition of Avastin improves resectability. But again, many of these patients for us in our center, are started on chemotherapy by outside centers and may have been sort of referred as a secondary thought. But yeah, we are seeing patients with Avastin. Again, if want to be really aggressive.
Okay, great. Dr. Kubi, do you want to share your last few slides there? And we'll try to not to keep everybody all night, but it seems like people want to see.
Thank you. Can you guys hear me and see this?
Yep.
And Sean, that was a great talk. Oh my gosh, send those slides to everybody because that is a great summary. So thanks, great honor. Really, I'll summarize. I think there's the recent publication, Annals of Surgery, of a series by MGH in Verona that sort of refutes a paper that we published about 5 years ago, also published in Annals of Surgery. And really the question was this, is if you do a Whipple for pancreatic adenocarcinoma, again, not IPMN or other diseases, and you transect the pancreatic neck and remove the specimen, and you send your specimen over to the pathologist and they assess the margin and they say microscopically you have an R1 margin, should you do this to get a negative or an R0 margin before you leave the operating room? Does that maneuver result in a survival advantage or at least get the patient back to where they should be with a clear margin in the first place? So why did this question came up? A study out of Moffitt really caught my attention in Annals of Surgery in 2009. They looked at 3 groups of patients, 141 patients who had R0 at time of resection and 44 patients who had R1 at the end of the operation. And then this third group that was R1 in the operating room converted by frozen section to R0 with an additional margin of pancreas taken. And when you look at the 3 groups, you saw the survival of that group converted from R1 to R0 was the same as the survival for the group that had an R1 final margin, meaning taking that additional pancreatic neck margin didn't make much of a difference. Subsequently, another study, there's the Moffitt study here, and then the Mayo study published subsequent showed exactly the opposite, that if you took that additional margin, you actually improved the patient's survival. So then we did a study through Emory that mimicked what we saw with Moffitt with an intermediate number of patients, about 400 patients, showing that that converted group from R1 to R0 didn't do so well, actually looked like a final R1 margin. Really, the question that came up from all this was, okay, we have 3 studies, they show conflicting things, so let's do this better. So our Central Pancreas Consortium in 2014 presented American Surgical a paper. It's 9 different centers collecting data. We worked together. We published over 25 papers, and 8 of them have been presented at the American Surgical Association. And the question was, again, the same question: do surgical margins matter for pancreatic cancer? So if you take all comers of 1,400 patients, yeah, if you have a negative margin, you do better than if you don't have a negative margin at the end of the operation. But the question is it really the surgical technique and the prowess there, or is it really an issue of biology? More likely to get a negative margin in a patient with disease that's more manageable. So when we did this study, this is the result. The blue line is the survival for the patients who had an R0 margin right from the start. The red line is the patients who had an R1 margin from beginning to end. And then the green line is the group of patients that were converted from an R1 to an R0, which fell exactly in line with the patients who just had an R1 margin. So the summary from this was, you can take the additional margin, but you may be fooling yourself that you're trying to combat bad biology of pancreatic cancer, and that the cat's out of the bag, and taking that additional margin, patient's still going to fail in a distant location. So we published this paper, and here's the fun part. Murray Brennan, my old chair from Memorial, got up and responded and said, after I finished presenting this in American Surgical, he says, David, I didn't know whether to be happy or sad. At best, as I can tell, I think I participated in the education of 7 of your co-authors, so it made me very sad to see that all 7 of you ignored what I taught. And just to fill this in, Dr. Brennan never sent a frozen section margin when he did a Whipple, and that's the bias or the interest that I had in studying this. Then he gave the follow-up comment, but I chose not to be sad. I actually chose to be happy that you and your colleagues went out and studied this, thereby demonstrating the skepticism we put in your mind. And then the final dig, of course, from Dr. Brennan was, even though it was a very comfortable effort. So subsequent to that publication, a study came out of Germany from Heidelberg, which had a smaller number of patients, single study over a longer period of time. And they showed that their patients that they converted from R1 to R0 did as well as their patients that had an R0 from the start. So all of a sudden, flying in the face of the data that we published. So I'm sorry, from Dresden, not from Heidelberg. So the Dresden study, however, though, had a mixed population of patients, Whipples and distals, and there were some IPMNs, not all PDACs in there, and their time frame was much longer. It was 20 years versus 10 years, so we had a much tighter data set. Then a subsequent meta-analysis came out on this question, and they included our study as well as the Dresden study. And basically, they looked at the comparison of how you did with an R0 versus an R1 converted to R0, and it was in favor of a better outcome for patients who had an R0 as compared to R1 to R0. And then when you compared the R1 to R0 to the final R1, they were right, they were equal or equivalent. So, again, it gave me some, additional confidence in our data. And then this published paper just came out now from MGH in Verona. So this is the question of the day. This is 986 patients. The two top lines are the R0 patients and the R1 converted to R0. And the inferior line with the worst survival is the R1, suggesting that that the results are very conflicting to what we published. As a matter of fact, they used the same exact study protocol we did. I felt both honored and targeted in this paper because my name's was tossed around many times throughout it. And so, then you have to read it critically and see what the differences between the studies are. Are they just better at getting that additional margin than we are? Again, we were 9 centers, so this is reflective of what's happening in the United States at the academic centers. So when I analyzed the data, this is some of the initial comments that I came up with. We used a different negative margin definition. A CPC study, our group used the Royal College of Pathology, so we were looking at greater than a millimeter margin, whereas the MGH Verona study used the on-FOSS definition. So basically any positive margin, they needed a zero, they used basically a clear margin, so not up to a millimeter. Second, the frozen section positive rate in our study was 11% and theirs was 20%, which also suggests either a difference in pathologic analysis or a difference in the study populations. Our study was larger, 30% larger, 1,400 patients versus 986 patients. And then finally, here's really, I think, the key thing that jumped out at me. Our tumors in general were a little more advanced, but also 600 of the 986 patients came from Verona, from Europe. The white versus non-white population, which does suggest potentially a difference in potential survival, was 97 versus 85%. And the neoadjuvant rate, or the pre-op chemotherapy, was double in the MGH Verona study, and the adjuvant rate of chemo receiving chemo was also higher in the MGH Verona study. So, I think the answer is you have two good studies showing conflicting results, and I think the question is still out there, and maybe this is a terrific thing to assess through a big registry. I don't think it'll ever be done in a randomized fashion, and basically, I would never say don't do a frozen section margin. I don't think really that's the point of the paper. I think the point of the paper is this is a disease with bad biology. And if you think taking a few additional millimeters of tissue is going to change the patient's survival when failure is usually distant, then I think you're sort of kidding yourself. So if we look at this, then you say, okay, if really that margin makes a huge difference, then you would think we'd be re-resecting margin recurrences. So I went back to my colleagues with the CPC, it's 13 fellowship-trained pancreatic surgeons, with 175 years of practice if you combine them. So I estimated in a very simple way that if they each did 10 Whipples for pancreatic cancer a year, that would be 1,750 Whipples for pancreatic cancer among this group. And I asked them how many had done a repeat resection for a margin recurrence, and the answer was there were 11 cases. So this is 0.6%. And of these 11 cases, it's uncertain how many of them were truly margin recurrences versus a second of primary. And I can comment in my own practice, I've only re-resected one, and it was a different surgeon had done the original Whipple, and this was a recurrence in the body tail of the pancreas that was not actually at the margin. So I think this is a rare event. So finally, I'm going to end with this. What do other surgeons do? What do the experts do? So I asked Matt Katz, a select group of pancreatic surgeons what they do. And here's what Matt Katz, Keith Olomo, David Linehan, and Andy Lowy said. They said they will check a frozen section margin, and they will take additional parenchymal margin once if it's positive, but they don't send that for frozen again. Nipun Merchant said, I will take an additional margin one time and be done with it. But every time I do this, I tell the chief or fellow that the data just doesn't justify doing it. Now, of course, he was a co-author in our study. Christina Ferroni from MGH says, I check margin. I'm willing to consider a total pancreatectomy, although at the time she had said she had never actually been faced with doing it. And my favorite response was from Peter Allen. He said, if you do a total pancreatectomy for pancreatic cancer, your patient will not live 5 years, but it will sure seem like it. So you take that as you will. Final margin philosophy. I think margins are particularly important for more indolent, slow-growing cancers that require more precise local control, as local failure is the concern. When you have an aggressive cancer like pancreatic cancer, then I think this is a systemic disease. And so margin negative resection should be the goal, and I am never questioning that. But I think you have to be mindful of patient harm and tumor biology. So those are my comments.
All right, great, thank you. We're now officially way over time, so I've given up on being a moderator at this point. But, so 2 quick questions then. Do you think that this paradigm will change as chemo gets better? So, I've heard Mark Trudy talk about this a little bit at different meetings, that as chemo gets better, systemic control gets a little better, local control may become more important. Do you think that that is going to change any of this? And kind of looking at some of the papers you referenced, the overall survival rates were somewhat low compared to modern FOLFIRINOX neoadjuvant series and all that. And then 2, in your practice, are you checking frozens on your Whipples for cancer?
So I'll answer number 2 first. If I am sufficiently away from the main tumor, especially if the patient's a little bit more flimsy, then no, I'm not checking it because I don't think it really makes a difference. Certainly if I feel like I'm close to the tumor, or if I don't know the diagnosis, or it's an IPMN or something like that, yes, I will check the margin. So I think that's a very fair question to ask me. But again, I'm not telling people not to check margins. It probably costs somewhere between $100 and $150 to check a margin. You wait a little extra in the operating room. And, I'll be very honest, it's not very nice, it doesn't feel good to go to the family after, or the patient after the operation, and say that the only positive margin was the pancreatic neck. But we also know it's not always that easy to take an additional margin. Sounds like it should be, but it's not always. So that can result in additional blood loss, additional time, and possibly put your anastomosis at risk, which is another set of issues. As for the newer agents and how that will shape and change things, with colon cancer, I'll use this paradigm. I thought when we went from just having 5-FU, yes, I'm old enough just to have had 5-FU in my practice, and that was for 50 years that was the only agent we had for colorectal cancer. When we started having irinotecan and then oxaliplatin, et cetera, I thought maybe the oncologist would just stop sending the patients because they would treat them to high hell with chemotherapy and never send them to the surgeon. The reality is the opposite's what happened. Patients we never would have operated on got sent to us for a consideration of resection. Different set of issues, obviously more complications when we operate on those patients. I think if we get more effective therapy, I think we're actually going to see more patients being sent to operation. Yeah.
Okay, great. Well, thanks everybody for participating, everybody on the Facebook feed, and obviously our speakers. That was an intense 2 hours of knowledge, so I really appreciate it from everybody. I'll just put a plug in. This was all recorded. This will be posted on the SAGE's website. So if you couldn't keep concentration or focus for 2 straight hours, it'll be there for your review. So again, thanks to everybody. Thanks to the speakers and for everybody that participated on Facebook. I think we'll shut it down. Thanks, guys.
Thank you.
Thank you.